uh, who has an interest in fluid management and in continuous renal replacement therapy and nephrology aspects in critical care. He's an excellent speaker. I attended some of his talks before, and he is really a supportive member for our activity in Pediatric Critical Care Society. Please welcome with me Dr. Al-Ubaidi. Dr. Al-Ubaidi as well, he's, as we mentioned, that working as a pediatric intensivist in University of Alberta Stillwell Children's Hospital at Edmonton, Alberta, Canada. And we hope that, inshallah, we'll have another lecture soon with Dr. Al-Ubaidi. And his talk is really amazing and very informative and opening eyes to what we are doing in the ICU. Dr. Rashid, the mic is yours. You can start your talk.
Thank you so much for the kind words. Very honored and pleased to be with you guys today. And hopefully we can have some nice and fruitful discussion on this interesting topic. So if we start, those are my disclosures. And when we're talking about fluid, I think it might be interesting to talk about the history and go down the memory lane about the first IV. So the first experience with using intravenous fluid was described by Thomas Latta in the late 1800s during the cholera pandemic. And in this case series that he published in Lancet, he describes how he was successful in reviving some cholera patient by using a homemade solution of sodium chloride and bicarbonate. He describes what I'm sure all of us seen when we're resuscitating a patient, how the IV fluid helped sharpen the features of the patients with the sunken eyes, the falling jaws, and the pale features, and the features of death, what he describes. And then he says that his patient began to glow with animation and life goes back to them. However, one of his colleagues, a few months later, he wrote an editorial with some concerns saying that the mass of profession is unable to decide in any form on uniform mode of treatment, and every town and village has its different system or systems when it comes to using IV fluid. He suggests that a suitable clinical investigation is required. And if we fast forward almost a century, this is a study that was published in the early or last decade that looked at cross-sectional assessment of IV fluid use in intensive care around the world. And indeed, every village had its own way of using IV fluid. After adjusting for patients and prescriber characteristics, country was a strong independent determinant of the type and way of prescribing fluid. And this is really understandable. When it comes to using fluid, it's a very complex intervention, and it varies depending on the different phases of critical illness. During the rescue phase, we have the question about what is the ideal volume and type for fluid resuscitation. And once we go into the optimization and stabilization phase, we have the questions about what are the optimal endpoints for resuscitation, what is the ideal rate and type of maintenance IV fluid, and then the question about whether fluid accumulation is a target for intervention, and what about the timing and modality to achieve so. We're not really going to address all of these questions. Each of these questions deserve its own talk and time, but we'll concentrate more in the first question about the ideal volume and type for fluid resuscitation. So if we go down to the memory lane and review the progression of the guidelines when it comes to fluid resuscitation and sepsis, I remember vividly when I was a resident, just starting my pediatric residency, looking after a septic patient. And I remember asking my attending at that time in the ICU about how much fluid I should be giving this patient. And the answer was 20 ml per kilo and go big or go home. Continue to give 20 ml per kilo as long as there is response and as long as there are no signs of crackles, hepatomegaly, or no further response on blood pressure. And that was the approach early on, but as the evidence continued to accumulate, there was a slight modification. If you look at the Society of Critical Care Medicine guidelines in 2017, they added a caveat that initial volume resuscitation requirement may be 0 ml per kilo if rales or hepatomegaly are present, but commonly are 40 to 6 ml per kilo. Subsequently, the Surviving Sepsis campaign in 2018 suggested that a minimum of 30 ml per kilo of intravenous fluid should be given. And they explained that there's little literature of controlled data support this volume. But they just decided to on this volume because this is the usual practice and there is observational evidence to support it. So what are the arguments for and against fluid and resuscitation and sepsis? Well, sick patients have a fluid deficit, and giving them fluid can help replenish some of that deficit. There is significant capillary leak during sepsis, and you need to replace that to increase the preload, increase the capillary driving pressure, and maybe minimize exposure to vasopressors, which have potentially negative side effects. The argument against overzealous or aggressive fluid resuscitation is that this fluid, when you give it to a patient who have capillary leak, it will leak into the tissues and cause fluid accumulation and subsequently fluid overload with all the complication that can happen with that. There's also data suggests that many septic patients only have transient or no increase in cardiac output after fluid using objective assessment of cardiac output. So it's not sustainable increase in cardiac output. Rather than just increasing the preload with fluid, when you give inotrope, it increases both the venous return, the vascular tone, and the stroke volume, leading a more significant and sustained increase on cardiac output. Also for fluid, the famous Rivers early goal-directed therapy trial showed significant decrease in mortality, and one of the components of the early goal-directed therapy was an average 5 liters of fluid given in the first few hours of sepsis. And there were many observational data in the early 2000s that supported early goal-directed therapy. However, the 3 follow-up trials, the famous ARISE, Prospect, and the other ones, looked at that early goal-directed therapy doesn't really improve outcomes. And the average volume given in these trials was between 2 to 3 liters. And there is overwhelming evolving evidence that suggests that there is potentially some harm to overzealous fluid administration. We're all familiar with the FEAST trial, with all its limitation when it comes to external validity and generalizability to the modern and tertiary intensive care environment. It raises some concern about fluid not being completely harmless, and that there's potential of harm in some subpopulation of sepsis. This study that looked at over 45,000 of septic patients in the state of New York that evaluated an early bundle that included the usual bundles for sepsis, found that what really matters is earlier antibiotic, earlier blood culture, and earlier lactate measurement, and that the delay in administration of 30 ml per kilo of fluid was not really associated with improved mortality. There's a very overwhelming evidence, observational, showing that the more fluid giving to patient with sepsis, the more risk of fluid accumulation and negative side effect, and also the same thing in pediatrics. With all that in mind, the most recent iteration of the Surviving Sepsis campaign downgraded the recommendation of 30 ml per kilo from a strong recommendation to weak recommendation, and that's based on the low quality of evidence. And they added that there are no prospective interventions comparing different volumes for initial resuscitation in sepsis or septic shock. And this is where our talk today comes in. We now have some evidence to support the recommendations in this area. The first trial that we're going to look at is the classic trial, which was published 6 months ago from Europe. 31 units in all around Europe that included around 1,500 patients. And it included ICU patients who received at least 1 liter of fluid in the 12 hours prior to randomization. The intervention was fluid bolus, only to be given according to pre-specified hypoperfusion criteria. It showed that patients received 3 liters on average before randomization. And this is an observation that makes sense. We usually don't admit patients to ICU until they receive the initial resuscitation in the emergency room or in the ward. And it's usually around the range of 3 liters in adults and around 30 to 60 per kilo in pediatrics. There was modest separation between the groups after randomization, with a fluid giving in the intervention trial for around, intervention arm of around 1,700 compared to almost 4 liters in the control group. However, that didn't really translate in significant difference in the cumulative fluid balance around day 5 of only 740 ml, which is a very minor difference when it comes to adult patients. There was no difference in the primary outcome, the 90-day mortality. There was also no difference in the secondary outcomes, serious adverse events. When looking at subgroup analysis, it seems that there was a trend that patients who required respiratory support might have benefited more from restrictive IV fluid. And those who have already received 30 ml per kilo also seem to benefit from more restrictive fluid after their initial resuscitation as compared to those who received less than 30 ml per kilo. It's a very well done trial with a lot of strength, but for the sake of time, I will just highlight some of the interesting points. There was large volume given, as mentioned, outside the trial protocol, around 3 liters at baseline. So this study seemed to evaluate more the value of restrictive late resuscitation after the initial resuscitation. As mentioned, the mean difference in resuscitation volume was around 2 liters, and the cumulative fluid balance was the difference was less than 1 liter. So this relative small difference suggests that the patient in the standard care were also treated according to a somewhat conservative strategy as well. Also, there are some concerns about the power of the study. It was powered to detect 7% decrease in mortality, which might not be realistically feasible with this small difference between the intervention and the control arm. The second trial that evaluated this question was the CLOVER trial, which was published 10 days ago in the New England and was from 60 hospitals in the US. And it evaluated a patient with septic shock who received at least 1 to 3 liters in the 4 hours prior to randomization. There was 2 arms. The intervention arm was an early vasopressor with only fluid for rescue criteria. And the comparison was further fluid, 2 liters, and further fluid boluses as needed, and only rescue vasopressor according to specific criteria. The trial included 1,500 patients. The majority of them were randomized in the emergency room. Patients received 2 liters on average before randomization, and there was nice separation between the two arms, both in the fluid given, almost 40 to 50% difference, and also in the vasopressor, with the restricted group receiving more vasopressor compared to the liver fluid. It's worth mentioning that the intervention was only for 24 hours, and the trial did not report fluid intake or balance after the 24 hours. Again, there was no difference in significant difference in mortality or the secondary outcomes or the serious adverse events. The subgroup analysis suggests that maybe end-stage renal disease patients have some benefit from restrictive fluid. An interesting finding from this study was that 500 patients received vasopressor via a peripheral IV with only 3 extravasation events, suggesting that peripheral IV for vasopressor is probably safe in adult patients. So if we try to put the two trials together, we can suggest that these studies did not confirm the pre-existing bias that restrictive fluid strategy is superior to the current standard care. At the same time, early or late restrictive fluid strategy is safe, but it's not superior to standard care. And it's really interesting that to see that the standard practice is really shifting away from the large volume resuscitation, and that it is a common practice right now to have a degree of restriction in the amount of fluid given to these patients. And this is an interesting phenomenon that we're noticing more and more with the trials in critical care that look at comparing new interventions to the standard of care. My own interpretation is that in the age of information where the knowledge is disseminated so quickly, sometimes hypothesis generating work as well as observational studies result in translation to the bedside and change of practice faster than the time needed to conduct experimental trials. I think it's in the current era of careful fluid resuscitation, we might not be able to demonstrate a large benefit of a restricted fluid strategy, because basically everybody's practicing a degree of restricted fluid strategy, at least in Europe and US where these trials were conducted. I think it's a very important finding to highlight that the peripheral vasopressor is safe, and would be interesting to see if the same would be applicable in children. I think the trials also highlight what's important in sepsis. Early antibiotics, source control, close monitoring, and hemodynamic support is probably what matters the most when it comes to sepsis. Whether hemodynamic support approach is that crucial, it's really hard to say. And even though these trials were large enough, they were not large enough to detect subtle differences by the vasopressor approach or fluid approach. And part of that could be because sepsis is a heterogeneous syndrome with various phenotypes. Some patients will have more capillary leak where fluid would be needed versus others where there's more significant sepsis-induced myocardial dysfunction where inotropic support would be needed. There's also cold and warm shock. There are comorbidities with respiratory or renal dysfunction. This is the highlight the importance of tailored medicine and individualized medicine. What these trials probably tell us is that some patients will require 60 to 80 ml per kilo, but others might only require 0 ml per kilo. And maybe future research should not fixate on the number, whether it's 30, 60, 80 ml per kilo versus more objective dynamic tools and evaluate the utility of those in sepsis. Maybe also we should study other important endpoints for resuscitation besides just blood pressure, and assessment of other surrogate of tissue perfusion might be also as important as microcirculation. And then stepping back and looking at the research in critical care in general, with the complex and advanced care, is mortality really the appropriate primary outcome in sepsis trial and critical care trial overall? Is it realistically feasible to detect statistically significant differences on mortality with just one single intervention? Or is it more appropriate to adapt some other patient-centered outcome, composite outcomes that are more easily to detect? At the same time, the question arises about if we should continue to adapt black and white hypothesis testing with p-values versus more sophisticated statistical approaches with probability testing, such as Bayesian statistics. So all these questions, I think, are valid questions that can be evaluated and discussed in subsequent work. Now, it's worth mentioning that there is another trial that's being conducted right now by the Australian New Zealand group called the ARISE fluid. At the same time, the Pediatric Canadian critical trial group just finished completing the SCCS study in Pediatric, and hopefully we'll have the results of this trial soon. The SCCS study evaluates both early and late restrictive resuscitation. The usual care arm, inotrope, is only allowed after 60 ml per kilo, versus a fluid-sparing arm where vasopressor is initiated after 30 ml per kilo, and fluid only allowed in certain after certain criteria are met. So hopefully we'll have more information in that area soon. Now, shifting gear to another topic, which is the type of fluid resuscitation, and specifically trying to look at the evidence evaluating normal saline versus balanced crystalloid solution. The concerns about the potential harm with normal saline were long-standing. This is an interesting editorial that was published in the early 1900s, where a surgeon in the US, in a very strong language, described his concerns about giving large quantities of normal saline. And as frequently as it happens now, he says it may result in great harm. And his concerns are understandable. There's nothing normal about normal saline. It was created by a Dutch chemist in the late 1800s, before the advance in chemistry, where he had bunch of solutions. The majority of them were hypotonic, and he found that what we called normal saline resulted in the least hemolysis when he tested them on chicken blood. However, now we know that it has super physiological sodium component, chloride component, and it is not buffered when it comes to its pH compared to the serum. There is experimental models, both in animals and healthy individuals, as well as observational data that suggests that there is potential harm from excessive normal saline administration. For example, this study from the US that looked at about 1,000 septic children retrospectively, and it found that hyperchloremia was, which we thought that it was generally meaningless and safe, is actually associated with increased mortality after adjusting for surrogate markers of severity of illness. This is a systematic review that looked at whether high versus low chloride fluid was associated with any benefit in adults, and it found that there is significant decrease of acute kidney injury with the use of more balanced solutions. So with all that in mind, we had few studies published in the last few years that looked at the question. The first one of which was the SMART trial from the US, a very large trial, one of the largest in critical care, that looked at 15,000 patients and compared balanced solution versus normal saline. And they found that balanced solution were associated with lower major adverse kidney events, and there was a trend to lower in-hospital mortality. What was interesting about this trial is this difference was detected with a very minimal fluid compared to the usual practice. Both arms of the unit only received 1 liter of fluid during the trial. And looking at the subgroup analysis, they found that patients who normally receive larger amount of fluid, septic patients, there was actually a statistical trend toward benefit with balanced crystal load. To further evaluate that hypothesis, the investigator did a secondary analysis, looked at sepsis patients specifically, and they found that balanced solution were associated with statistically significant mortality benefit after adjusting for potential confounder, about 25% decrease in mortality, which is a big difference. There was also improvement on secondary outcomes, including vasopressor-free days, ventilator-free days, and renal replacement therapy-free days. The other study that was published subsequently was the BASICS trial. Again, another very large study from Brazil that looked at about 10,000 patients. The majority of them had low acuity with planned surgical admission. There was no difference in mortality or secondary outcomes. Interestingly, they found some potential of harm in patients with traumatic brain injury. What's interesting about this study is there was a higher degree of contamination, both prior to randomization and during the study period, where patients received non-study fluid, not in accordance with the arm that they were randomized to. So to address the two concerns about the low acuity of the patient as well as the contamination, the investigator subsequently published secondary analysis where they looked at the type of admission. And again, looking at the sepsis patient, there was statistically significant improvement with using balanced solutions. We're looking at those who exclusively receive balanced solutions, so getting rid of the contamination that was found in the original trial. There was also a trend towards benefit, and using Bayesian probability statistic, this probability of benefit was around 92%. The PLUS trial came after that, and for the sake of time, not going to dwell too much into it. It showed no benefit with balanced solution. We're looking at the full cohort, and around the same time it was published, the investigator of the 3 trials did a very well put together systematic reviews, where they mainly looked at 6 randomized controlled trials with low risk of bias with a total patient of around 34,000. There was no statistical significant benefit when it's looking at mortality, with a confidence interval between 0.91 to 1.01. So what that means is a potential 9% benefit and to 1% harm. And they again did Bayesian probability testing, and they found that the actual potential benefit is around, or the expected potential benefit is around 90%. There was no difference in secondary outcomes, And looking at the subgroup analysis, again, sepsis, there was looking at the confidence intervals, potential of benefit more than harm. And with traumatic brain injury, the potential of harm was a little bit on the higher side. So putting it all together, fluid is the most common therapy administered to critically ill patients. And while these studies didn't show statistically significant differences when it comes to using balanced solution, I think the application of Bayesian statistics here is quite applicable because even minor changes in outcome trends can have significant implications on population level for a therapy that is used as extensively as fluid therapy. However, it's important to note that there is a dose-effect relationship. For the average ICU patient, there's probably no major risk for administering either normal saline or balanced solution. However, when we're using aggressive resuscitation and large volume resuscitation, I think balanced solution might have a benefit, and we should consider it for these type of patients. At the same time, there seem to be modification effect based on the type of patient, specifically for patient with traumatic brain injury. There is potential harm, and maybe we should avoid using balanced solution in these patients. Further questions that we need to look at is, are all balanced solutions the same? While they have a comparable chloride and sodium composition, they differ in the buffer qualities, and maybe there's some subtle difference between them that these trials didn't detect. So have we made any advances in the last 185 years since the initial normal saline and use and the development of these fluid that we still use to this day? I think the 4 or 5 trials that we talk about have helped greatly in clarifying some of the unanswered questions. But at the same time, I think, as Aristotle said, the more we know, the more questions arise. And this is exactly what we have at this point. And there are a lot of questions that we still need some time to answer. And with this, I conclude my talk. I hope you find it useful, and I will be more than happy to share a discussion with you on this. Thank you so much.
Thank you, Dr. Rashid, for this great talk. It's really a big question around the amount of fluid, timing of fluid, and the type of fluids that we should really use. The floor is open for the colleagues. If anyone have any comments or questions.
Assalamu alaikum, Dr. Rashid. Thank you very much. You can hear me, dear colleagues?
Yes.
يعطيك العافية حكيمة. Thank you very much. Really enjoyed it. Really, thank you for going through this extensive literature, both adults and pedia. And I really love your last statement slide. Really, the more you know, sometimes the more puzzled. So how would you state it in your own words, Dr. Rashid, for the colleagues, especially our juniors? So how can they tailor their treatment to, as you mentioned, to the individualized patient's care? So how would you, what will be your take-home message, especially for those new with us coming to the PICU practice? Again, thank you very much, and nice to see you in great shape, Hakim. Thank you very much.
Thank you, Dr. Timsah. It's really nice hearing your voice. And very, very good question. I think it all goes down to evaluating the patient as a whole and trying to incorporate as many data points as possible. It's a cliche, but I think it's really applicable. Some patients will have history suggestive of dehydration, they examine and look dehydrated, and the response to fluid is more profound. And those are the patients that probably you would consider trying fluid and evaluating the response and looking for more objective assessment. I think the value of POCUS at the bedside need to be utilized. Pulse pressure variation is another potential tool to utilize. But ultimately, I think the physical, the history, the response to intervention, and rather than just having a cliche of, oh, every sepsis patient need to receive 30 ml per kilo to 60 ml per kilo. No, every patient is different, and you need to evaluate your patient as an individual. So I wish I have the $1 million, the answer to the $1 million question about what's the gold standard. But at this time, I think it's the patient as a package, and all the data points can help us decide. I think following the Surviving Sepsis campaign suggestion of 30 ml per kilo as minimum, and after that, it goes back to individual medicine practices and a style of how to proceed with fluid versus vasopressor.
Thank you, Dr. Rashid. Thank you, Dr. Hani, for your question. Any further questions or comments from the colleagues? Can you tell us about your practice and your centers, how you usually approach the fluid management with in critically ill children? Do you go with the process of frequent assessment versus restricting fluid from the beginning? And what kind of fluid that you use in your centers?
Yeah, I think the practice within our group is probably a microsome of the practice within the whole critical care community, in the sense that some of us are more liberal versus others that are more restrictive. To me personally, I'm biased with some of the work I did. I'm more in the anti-fluid camp. So I typically lean more towards starting inotrope early. But there are the odd patients where I find that their capillary leak is quite significant, that a little bit of extra fluid on top of the usual 30 to 40 per kilo is not harmful in a sense, and maybe beneficial. When it comes to type of fluid, I think balanced solution for septic patient and patient who receive large volume resuscitation is probably the safest approach based on the evidence that we just discussed. And although you could argue that there is no, the study didn't show, a very strong convincing argument, the fact that we have physiological basis in saying that normal saline is not normal, and that the price value from economical point of view between balanced solutions as compared to normal saline is not that different. With the potential benefit of balanced solution, I lean more toward using balanced solution in my practice. And I think many of my colleagues also do that.
I do agree with you, Dr. Rashid. So the same for us. Talking about myself and the way that I go, we were actually initially very generous with the fluids. Lately, in the last few years, we start to really be aware of, fluids-related morbidities in the ICU. So in generally, I go with the approach of restricting fluids early on, unless if there is a clear indication to give more fluids. and trying to start functional fluid rather than non-functional fluid. And to remind the colleagues that always IV fluid is a medication that should be used wisely and not to be very generous with this unless if it is really needed. And that seems to be helping. As you mentioned that in the studies still, we don't have really a strong directions, but at least people they start to be aware of, more is not always better, and we should reevaluate our practice. I think we have Dr. Saleh al-Shehri.
السلام عليكم ورحمة الله وبركاته.
تفضل دكتور صالح.
عليكم السلام ورحمة الله.
Thank you very much. I enjoyed your talk very much about the journey of the evolving evidence. It's very difficult. Back to Dr. Timsah comment. Whenever you want to apply the evidence with this complexity of windows of how to look to your patient in terms of the underlying cause of the shock, in addition to the stage where you start to handle the patient. Maybe we share all one thing together, that majority of our patients not under our direct care. For example, there's some bulk of patients who's coming from the ER, and then they have some over or under resuscitation according to the center to center variation. So I find it, for example, in a center where I'm working, the colleagues of ER, they are over in terms of the initial resuscitation. But again, there's many factors that sometimes affect indirectly the ultimate outcome of whatever you're trying to measure related to the fluid resuscitation, whether early or late. But I can tell you that people are looking to the type of fluid, as you discuss in your review. We're just asking ourselves how often we are looking to the type of acidosis or ongoing acidosis, if it is true tissue perfusion issues or it is saline induced, and is it something really ICU practicing and they're taking action based on to change the fluid or to start to back off. This is something I think there is big variation in the practice. Number three, if I want also to think about the initiation of inotropes, the philosophy of inotropes, again, it's one factor that making all the evidence is really difficult to interpret and to adjust for the fluid itself. What I'm seeing, Dr. Ubaid, what do you think, looking to the blood pressure as a surrogate to all the intensivists, maybe all the critical care? Most of our practice so far, we are linked with the blood pressure as a tool to maintain in a certain target. And there is some evidence evolving. Our colleagues in the last critical care conference, they talk about stretching blood pressure is sometimes is like harmful, and they bring very good evidence about this in cardiac ICU. What do you think? Do you think the blood pressure as a tool is gonna change in the future to guide you for the adequacy fluid resuscitation? Thank you very much.
Thank you, Dr. Saleh. Yes, I agree with your comments about the complexity of applying the evidence at the bedside and to individualize it to the patients. I think you raised some good points about the variation in practice. And I think the studies we discussed today show, at least if we, whether you decide to be extra or over restrictive with your fluid versus somewhat more liberal, that both approaches are reasonable. And then the researchers and the trialists will need to look more into the subgroup population and the variation within that practice. But as it stands now, I think the overall message is that it seems the majority of the intensive care community agree that a degree of restriction of fluid and avoiding the overzealous administration of fluid is the way to go. And at least we know, based on the 2 trials we discussed today, that it's a safe approach going forward. And now, when it comes to what should be the endpoints of resuscitation, I think that's an important question. We really should be moving away from the numbers per se and looking at the patient. Yes, map of 65 in adults versus 60 versus 55, or in kids, depending on the age, is just a number, and whether it really targeting that number is really what translates to benefit or not. This is all what we have right now. But I think it's a very valid research question, and I agree with you that there's some studies looking at that suggest maybe permissive hypotension approach, which result in less treatment offered, might be as good with less side effects. However, I don't think we have the strongest evidence to change our practice right now, but it's certainly an important question to evaluate going forward. Thank you.
Dr. Hana, do you have a question, Dr. Hana?
Assalamu alaikum. Thank you very much, Dr. Rashid. Dr. Hana, Pediatric Intensive from تخصصي دمنام. Thank you very much, Dr. Rashid, for your amazing and rich presentation. I really enjoyed every single slide. My question is, what is your thought and experience in using non-invasive cardiometry in tailoring the management in patients with septic shock, whether the dose of the fluid, resuscitation, and the use of inotropes and vasopressor? My second question is, from your practice, do you find any difference in approaching a cancer patient in the management of septic shock? And the reason I'm asking that, our observation in cancer patients, they usually respond to early administration of hydrocortisone. So it seems okay that they have some sort of adrenal insufficiency. And other cohort as well, okay, they have like a very bad vasoplagia. So I just wanted to hear from your experience in regard to this subject. Thank you very much, Dr. Rashid, again.
Thank you. Very excellent questions. The question about what is the ideal tool to guide fluid resuscitation is very interesting. And I think the intuitive stance is that, yes, the more information that you get, the more information you will be utilized and the good outcome you will have. However, the counter argument and what some of the opponents to that argument without a strong evidence is the evidence that showed that pulmonary cath doesn't improve outcome. Although it provides information and it adds significant information that guide our management. So depending on which camp you subscribe to, I think we definitely need to evaluate it. And I think in the right settings with the right approach, whether it's focus versus non-invasive cardiac output monitoring, this is really where the next trials should be evaluating. And I'm hoping that there is something coming the pipeline that will look exactly at that question. Does incorporating non-invasive objective parameters help us when it comes to patient-centered outcome? There's certainly some evidence that show that it helps decrease the fluid, that it helped decrease the inotrope, but whether that translates to patient outcome, that's something to be seen. And I'm hopeful that the future trials will look specifically at that question. Your other comment about the phenotypes of sepsis is absolutely correct. We all seen in our anecdotal experience, the more we work, the more we can identify septic phenotypes. There are some patients, the chronically ill, such as cancer patients or complex kids, hydrocortisone early on seemed to help. There are certain patients with line sepsis and cancer patients. Those kids will have a very bad, significant vasoplegia, where early inotrope would work better than just hammering them with fluid. And this is, I believe, will be the next important step in sepsis, is trying to identify the phenotypes of sepsis and tailor the management accordingly, rather than just treating the sepsis syndrome as a whole as just one disease with one approach. So thank you so much for these comments. I agree with them completely.
Thank you, Dr. Hannah, for this excellent point. I think we do have Dr. Yasser Gazzaz.
Assalamu alaikum.
Yeah.
Thank you all. يعطيك العافية, Dr. Rashid. I don't have any questions. It was a comprehensive review and a lot of new data, even when we read about this topic a lot nowadays. I'm just saying, because there has been a lot of questions about future research and what will happen. I'm aware that Dr. Rashid is conducting actually change of projects that I hope someday it's going to reach kind of a multi-center randomized control trial, and hopefully that's going to involve us in Saudi Arabia. And I know one of the projects that we are part of, that he sent a survey to look into our current practices in fluids, and maybe if in the future the people who answered, they want to participate in a future research. So I encourage the consultants who received that survey to answer it. يعطيكم العافية. شكرا دكتورة عايدة on moderating this session. It was really a great session. Thank you.
Yes, shukran Yasser. I'm sorry that probably your emails were bombarded with the survey invitation. Thank you for all of you who responded to it. I would really greatly appreciate if you have the time, for those who didn't, to respond. We're hoping that the survey results will help guide us implementing an interventional trial down the road. So your participation will be greatly appreciated. Thank you.
Thank you, Dr. Yasser, for this comment. Let's see if we have any more questions or comments from the colleagues. Can you just unmute yourself?
Yes, Assalamu alaikum, Dr. Rashid. Thank you very much for the nice presentation. I'm Dr. Mussin, acting consultant in Pediatric ICU, King Saud Medical City. My question was just regarding if there is any update in the guidelines for pediatric burn patients regarding the fluid management in the initial phase.
Yes, thank you. I think it's a very timely question. I had a burn patient last week, and I was finally pleased to see my plastic surgeon colleagues agreeing with me and joining me in the less fluid camp. So as we all know, we used to do the Parkland formula where we hammer these patients with fluid, understandably so, because they have high degree of fluid losses. But it seems the guidelines and many of the surgeons are moving away from treating just the number, with every patient need to have, I don't know, percentage of fluid for each percent of burn, to treating the patient at the bedside and using more dynamic assessment, which is urine output. As per my discussion and reviewing the recent evidence as recent as last week, it seemed there is more shift towards targeting, rather than just using a number of, this is how much fluid you need to get, is just targeting urine output of more than 1 ml per kilo per hour for otherwise normal kidney function patient. So this is an excellent example where the practice is moving away from one bill fits all kind of approach to a more objective, dynamic assessment of the patient and treating the patient in an individual way. Thank you for the question.
Thank you, Dr. Rashid. I think that's all for tonight. It was really an interesting topic, and questions definitely will continue to be there, looking for more evidence to help.